to ask your permission. Okay, thank you. All right, great. So welcome everybody. I'm very happy to see everyone here. I know it is, it's a weird time. People are graduating or leaving for vacation. So I'm super happy that you're here. For those who are not, no worries. We will be recording this event and you will have an opportunity to watch it later. So my name is Eleni Militsakaki. I am a member of the Hellenic University Club, and I'm super excited to introduce our third speaker on the Young Scholar Spotlight series of speakers. Our speaker is Dr. Artemis Zavaliangos-Petropulu, and she's the third speaker, as I said, and the last one for this academic year. And we are very pleased because Artemis is a former scholarship recipient, former Hellenic University Club scholarship recipient. And we thought that you'd love to know where people go, right? After they graduate and, they get the scholarships for the amazing work that they have already done during high school. Where are they after that? And of course, we're not surprised to see where their paths are taking them. Artemi, I will not say a whole lot because I think Artemi already has something. She will talk a little bit about herself, but just to give you the basic strokes of the amazing career that she already has, and I don't know if she's 25 yet or somewhere there. Artemi graduated, she studied psychology and neuroscience. She did her BA at the University of Southern California. And then she did her PhD in neuroscience at the University of Southern California as well. And now she's a postdoc at the UCLA Brain and Mapping Center and is doing very interesting work on the neuroscience of depression medicine that she will talk to us about. She's local, she's from our area. She's in the family. And as I said, I don't want to say much more because I think she will tell you a little bit more about her own story. But before I pass it on to Artemi, I just want to give you like a few Zoom tips, please, if you can, or when you can, or if you feel comfortable and you don't have bandwidth issues, turn your cameras on. I think it's nice for the speaker to see your faces. Please mute your microphone unless you're speaking. There will be an opportunity to ask questions. Please provide nonverbal feedback by using the control with raising hand if you want to say something or if you want to briefly interrupt for a clarification. And of course, to use the chat if you want to send messages while we are talking. You can tell if something is not going well, if there are any sound issues, whatever. Comments that you want Artemi to look at later, anything you want, the chat is there for you. So without any further delays, I'm gonna pass it on now to Artemi. Artemi, thank you so much for accepting the invitation. And we really look forward to hearing your talk. I'm going to stop sharing immediately and give the ground to you. Okay, welcome, Artemi.
Good. Okay, so I'm gonna do what we just did to make sure it works. Okay, do you see slides and not notes? Yeah, okay, good. So thank you so much for inviting me to speak. I'm really excited. There are a lot of familiar faces I see here from St. Luke's days and another lifetime ago. So yeah, my name is Artemis Zavaliangos-Petropulu. I am a postdoctoral fellow at UCLA, both in the neurology and psychiatry department. My advisor is Dr. Catherine Nahr, and today I'm going to be talking to you about my work studying ketamine treatment in treatment-resistant depression and how we can use brain imaging to do this. Okay, so again, some background history about myself. I graduated from Shipley in 2010. I grew up in Bryn Mawr. Then I went to USC. We covered this. My background during graduate school, my focus was mostly on neuroimaging analysis. So I was doing some brain imaging to study how people recover from stroke. So now in my postdoc at UCLA, I'm actually applying those neuroimaging skills to a different brain condition and looking at mood disorders. So depression, this is what we're going to focus on today. Colloquially, you'll hear people talk about feeling depressed synonymously with feelings of sadness or grief. For example, I was so depressed after the Sixers lost in the playoffs this year. Sorry for the triggering photo. While many of you may have felt sad, the next day you were probably able to get out of bed and go to work or go to class and continue your life. There's always next season. Next thing you know, it's baseball season, the Phillies are on a winning streak, and life is okay. So that feeling of sadness is different from feeling clinically depressed. Clinical depression, or major depressive disorder, includes feelings of sadness as one of its symptoms, but as a whole, it's a little bit more complex and more pervasive. It's not really something that you can just shake off. So to be diagnosed with major depressive disorder, you need to have at least 5 or more of the following symptoms. So feeling sad or empty, feeling excessively guilty, poor memory, difficulty concentrating, difficulty with decision-making, thoughts of death or suicide, lack of sleep, lack of energy, finding no pleasure in daily activities or your hobbies, feeling socially isolated or socially isolating yourself. So now you can imagine having any one of those symptoms can be really difficult, but imagine trying to juggle 5 or more of these and think about how much that might impact your quality of life. It's pretty hard to hold a job or maintain a good relationship. So how prevalent is it? Unfortunately, pretty prevalent. 322 million people suffer from depression worldwide. 1 in 5 people actually suffer at least one depressive episode before they become adults. Now, given this prevalence and how hard it is to live with depression, the World Health Organization has actually declared depression as one of the leading causes of disability worldwide. This alone is concerning, but we also know depression can lead to suicide. So according to the CDC, these are really upsetting facts, but in 2020, almost 46,000 people in the US died by suicide. That's terrible enough, but there's millions of people that year who seriously thought about it, planned a suicide attempt, or actually attempted suicide. So you can understand there's a very urgent need to understand what's causing depression and how we can treat it. So what is causing depression? This is the gajillion-dollar question. It could be situational. Maybe there's some kind of traumatic event that happens in your life that ultimately triggers this clinical depression. Could be the Sixers losing, but it could also be the death of a loved one or some form of physical or emotional abuse. One of the oldest theories of depression is that it's a result of chemical imbalances in your brain. There's some evidence that there's a genetic component. You might inherit it from your family. It could be a result of a physical illness or a medical condition. For example, postpartum depression is very common. Diet has actually been linked to depression. Substance abuse, aging, even pollution has been linked to depression. So it could be any one of these individually. It could be any combination of these. We don't know. And that's pretty frustrating. And the thing that's particularly hard about this is, unlike most medical conditions where you can go get a blood test or get an X-ray to make a diagnosis, we don't really have a good objective marker of depression. So we just have to go based on what symptoms you present and try our best to treat them. So if you start presenting with depressive symptoms, typically your first stop is going to be psychotherapy. This is where you talk to a psychologist, a therapist, a licensed clinical social worker, and through verbal communications, they use a variety of techniques to try and help you shift your negative thinking. Now, sometimes psychotherapy alone isn't enough, and you need pharmaceutical intervention. So this is where antidepressant medication comes in. I'm going to turn on my laser pointer so that I can point to stuff. Okay, so a lot of commonly prescribed antidepressant medication today is based on the early models of depression biology that focus on neurochemical imbalances in your brain. So what does that mean? Your brain works using chemical signals that we call neurotransmitters. So if you look here, this is actually a brain cell or a neuron, and they line up next to each other. So right here, where one brain cell is talking to another brain cell, we call this area the synapse. And these little red dots are the chemical signals that transfer information from one cell to the next cell. And so commonly used antidepressant medication directly affects neurotransmitters that are responsible for regulating your mood. So for example, serotonin is an important neurotransmitter for mood regulation that's responsible for, or thought to be responsible for behaviors like happiness and feeling calm. And people with depression are thought to have less serotonin available. So you might be familiar with Zoloft. It's one of the frequently prescribed antidepressant treatments. So Zoloft is an SSRI, or a selective serotonin reuptake inhibitor. It's a fancy way of saying, essentially, it tries to make serotonin more readily available in this space so that it can try and jumpstart those feelings of happiness that have been muted with depression. What's tricky with these antidepressant medications, though, is they take a long time to kick in. It's typically not until 6 to 12 weeks after a patient has started their medication that they start to feel symptom relief. So from the time that you first start experiencing your depressed symptoms to the time that you feel better, we call this a depressive episode. And what's interesting about depression for a lot of people is sometimes we can't actually cure it. For more than 50% of people diagnosed with major depressive disorder, they end up relapsing within 5 months of clinical remission. This means they have to repeat that cycle. They have to repeat that depressive episode multiple times in their life, and they have to go through different treatment options. Unfortunately, roughly 1/3 of patients never benefit from these antidepressant medications. So essentially, they kind of get stuck in this depressive episode. What's particularly concerning is how difficult it is to treat depression, again, is the alarming rate of the alarming mortality rate. So 15% of people with repeated depressive episodes commit suicide, and it's estimated that 30% of people with who don't benefit from these treatments attempt suicide. So there's an urgent need to develop more effective and faster acting interventions, especially for someone with severe depression who's presenting with a lot of thoughts of suicide, or what we call suicidal ideation. Someone like that may not have 6 to 12 weeks, especially if these conventional medications haven't worked for them before. So there's been a recent surge in research focusing on how to identify rapid acting interventions. So in order for a treatment to be considered rapid acting, it must provide symptom relief within 1 to 2 days of being administered. So you can think of this as almost like emergency medication. So today we're going to focus on the people who don't respond to antidepressant medications. We refer to these people as having treatment-resistant depression. And there's a growing number of rapid interventions for treatment-resistant depression that's a little less specific than focusing on just one neurotransmitter, but instead tries to remodel connections throughout the brain. It basically tries to change brain circuitry in a process we call neuroplasticity. So one of the more well-established treatments for treatment-resistant depression that's very fast-acting is electroconvulsive therapy, where you apply essentially an electric shock to the brain. Now, I get a lot of negative reactions from people when I mention electroconvulsive therapy because their mind goes to the really scary scene from the movie One Flew Over the Cuckoo's Nest. And I'm here to tell you medical technology has advanced in the last 40 years, and it's not nearly as barbaric. Instead, patients undergo anesthesia. It's not a painful process. In fact, it can actually be life-saving, especially for these people who have treatment-resistant depression. Now, it does come with some pretty serious memory side effects, but people with treatment-resistant depression tend to be so desperate for symptom relief that they're willing to make that trade-off. So as you can imagine, we don't want them to have to make that trade-off. So there's been a lot of research going into identifying alternative treatment options. So some of the more experimental ones that include sending electrical current to the brain, but at a much lower degree, is transcranial magnetic stimulation and transcranial direct current stimulation. Now these both are a little bit more experimental. They're typically not prescribed at the doctor's office, and we're still trying to understand their efficacy. And another rapid intervention is total sleep deprivation, which is exactly what it sounds. And miraculously actually works really well for depression, but as you can imagine, is something that's really hard for a patient to integrate into their daily life. Now, one of the newer rapid interventions that's gaining a lot of attention these days is ketamine, and this is what I'll be focusing on today. So ketamine as an antidepressant is relatively new. They only started using ketamine as an antidepressant in the last 20 years. And what we see is fast and pronounced reductions in depressive symptoms in patients with treatment-resistant depression. It's actually been described as arguably the most important psychiatric discovery in a half century. So in order to get into ketamine as an antidepressant, we need to talk about the history of it and how we got here. It's a really interesting journey. And we're going to start with phencyclidine, or PCP, also known by its street name, angel dust. So back in the 60s, that was kind of the heyday of psychotropic medication discovery. And as they were creating these new psychotropic drugs, they came up with PCP, and they realized that it's actually a really good anesthetic. So it could potentially be used in hospital settings to help anesthetize a patient, knock them out, so you could do a medical procedure. One of the reasons why they thought it was so promising is that when they gave participants a patient's PCP, they actually had preserved airway reflexes, which is really important because for a lot of anesthetics, that even ones that we use today, a patient can't breathe on their own. You have to intubate them. With PCP, you don't have to intubate them. They can still continue to breathe. Additionally, they were pretty excited about PCP because it had a really good safety margin. So essentially, a fatal dose of PCP is several magnitudes higher than the dose that requires for anesthesia. So there's no serious risk of accidentally causing a patient to overdose. Now, as I can probably imagine, most of your first reaction when I say PCP, anesthesia, there's some insane side effects of this, right? This is why you don't hear of people using PCP in hospitals. What actually happens is during the clinical trials, they were finding that patients would wake up from surgeries with these crazy hallucinations, convulsions, and general symptoms that resembled schizophrenia. Not good, not what you want, especially when the patient has to recover from the whole trauma of their medical condition. So ketamine was developed in an attempt to find an alternative to PCP. It's actually an analog of PCP, so it's chemically similar. And what they found is ketamine shared the benefits of PCP, but with less scary and much shorter lasting side effects. Additionally, one of the added bonuses that they found with ketamine is that it actually is an analgesic, so it provides pain relief. And so in 1970, the FDA approved ketamine as an anesthetic and an analgesic. It actually became a really popular battlefield anesthetic during the Vietnam War, and the World Health Organization today still lists it as an essential medication. That doesn't mean that the side effects aren't there. It's a toned down version of PCP, but it still causes a weird state of delirium. So patients experience an unusual state of consciousness and dissociations. Oftentimes they report feeling like they're floating outside of their body. Due to its euphoric effects, ketamine also became a popular recreational drug and remains a Schedule III drug of abuse today. So for those of you who are unfamiliar with drug scheduling, the government classifies drugs based on medical value and potential for abuse. So a Schedule I drug has no medical value, but very high potential for abuse. So an example would be heroin. Moving down those drug schedules, essentially they increase in medical value and decrease in potential for abuse. So a Schedule III drug has medical value. You can get it through a prescription, but it's not available over the counter. Typically, it has a low to moderate risk of physical dependence, but a slightly higher risk of psychological dependence. So ketamine actually lives alongside Tylenol with codeine as a Schedule III drug. It has a pretty good safety profile. So again, it's very difficult to overdose on ketamine or become seriously physically addicted to it. And also when administered, the patient won't feel any serious physical withdrawal effects or this kind of hangover effect. Now, ketamine is also used as an antidepressant, but when used as an antidepressant, it's administered at a much lower dose. So it's not going to knock you out. In a hospital setting, an anesthetic dose is roughly 2 milligrams per kilogram. So depending on how much you weigh, they give it to you really quickly over 60 seconds. And that results in 5 to 10 minutes of anesthesia. Now, ketamine as an antidepressant is administered at a sub-anesthetic dose. So it's not going to knock you out. You'll still be awake, And it's a fraction of the dose that they give to you in a hospital. So it's 0.5 milligrams per kilogram, and they give it to you over the span of 40 minutes. So typically ketamine is administered intravenously through an injection, like you see here, the IV. There are oral pills and nasal spray versions of ketamine that have been developed, but they're not quite as effective as the IV version. So this here is a patient receiving ketamine treatment. One of the things to note is there is a medical professional here, both administering the treatment and checking on the patient throughout the infusion and the hours following. Ketamine is not an antidepressant that you take at home. So I don't want anybody to imagine that these people are taking antidepressants and having dissociative experiences like in their bedroom. This is a very controlled setting. But how did we get from anesthesia to antidepressant? That's still a jump. Remember when I said PCP actually caused schizophrenia type symptoms? In the late 80s and 90s, there was a lot of research being done using PCP to try and mimic schizophrenia symptoms so that they could learn more about schizophrenia. And because at the time, ketamine had actually been approved by the FDA, it was much easier to acquire for these clinical trials. And so a researcher at Yale was like, okay, well, they're chemically pretty similar. Why don't we try to induce schizophrenia type symptoms using ketamine? So the legend has it, as they were trying this out, in follow-up sessions, when they were checking back in with the participants of their study to see like there are any lasting negative side effects from participating in the study, they actually found that there was a good side effect. They were mood enhancing. So in 2000, they performed the first placebo-controlled double-blind trial investigating ketamine as an antidepressant in depressed populations. So what does this mean? A double-blind controlled placebo trial means that half of your participants are going to receive ketamine and the other half are going to get a saline injection. So it's not a real treatment. And we can see here the open circles are the people who received the placebo, and there's not a significant change in their depressive symptoms, but the people who received ketamine saw a profound reduction in their depressive symptoms that started 240 minutes after the infusion and continued to decrease in the 24, 48, and 72 hours after the infusion. So this was really incredible. And there's been a lot of research that's been done replicating this and checking this out in different populations. And they've actually found that there's a 60 to 70% response rate in people with treatment-resistant depression. So this is truly amazing. And again, it's rapid acting. So we see the clinical effects typically show up 2 to 4 hours after the ketamine has been administered. And so again, it's improved depressive symptoms and reduced suicidal ideation. Now you might be wondering, how long do these effects last? People with treatment-resistant depression have been battling this depression their whole life. This isn't a miracle drug. The effects are relatively transient. So typically the depressed symptoms come back after about a week. In the last few years, though, people have been testing out different types of multiple infusions. So we call this a serial infusion, and they're still trying to figure out what's the right dosage, how many infusions a person should get. But with some of the standard serial infusions, we see depressive symptoms being delayed for almost 20 days. Now, this isn't to say that it's not without side effects. There's a really interesting New York Times article that just came out in December called "I Took Ketamine for My Depression and Things Got Pretty Weird." So this person has depression and they received a ketamine treatment, and she reports the experience as, "Sometimes I felt I was an elephant swimming under the sun, an extroverted octopus, or a balloon slowly inflating. I repeatedly requested the presence of a dog. I also grew giant hands." She also describes an infusion of ketamine is like taking a 2-hour Uber trip with a clown, which to me, I'm not sure if there's anything worse than that. But luckily, these side effects really only peak within 1 hour of getting the infusion and typically resolve within 2 hours after infusion. So again, that's why when depressed patients receive this ketamine treatment, they're monitored for a few hours after the infusion until their side effects go away. Other than that, so far, there haven't been any serious adverse events that we've seen, but a lot of these follow-up studies, because again, this is a relatively new field, they haven't been looking super far ahead. So this is like, for example, there's this a really strong meta-analysis, but they were only looking at 3 months after the treatment. So where do we land with the FDA? the ketamine treatment I've been discussing, the intravenous one, which is this one here, technically is not approved yet as an antidepressant. It's available off-label. So this means an off-label drug is a drug that's been approved by the FDA, but for a reason other than why you're using it. Unfortunately, this means it's not covered by health insurance yet. So people who want to receive ketamine treatment can receive ketamine treatment. It can be prescribed by their doctor, but they have to pay out of pocket. Now, there is one FDA-approved version of ketamine. It's called S-ketamine. It's a nasal spray. And it's only available at certified doctors' offices and clinics. Again, requires all of the same medical supervision we've been talking about. But the thing is, in terms of how effective it is, they're still investigating, but it's not quite as strong as the IV version. Just this January, this European company cleared a stage 2 trial for an FDA clinical trial looking at a different version of ketamine, and we're excited to see how that works. But I think it's important to note that while ketamine seems to be really promising, there's a lot we don't know and a lot of grains of salt that we have to consider. So there's limited studies investigating its long-term use as an antidepressant. What we do know from ketamine abuse studies is that high prolonged levels of ketamine can actually be toxic. Specifically, it can cause bladder damage and cognitive impairment, which is something to consider. We also know that people can develop a tolerance to ketamine, so we have to be careful with how we prescribe this treatment. Additionally, ketamine treatment is very expensive. You can't get your health insurance to cover it because it's off-label. And what we're seeing is a lot of these psychedelic wellness clinics popping up and charging people anywhere from $400 to $1,200 per infusion. So I think it's important to note right now that given the risks, we can't recommend ketamine just for anyone. There's a lot of stuff that we need to learn about it. But I think there's plenty of proof that despite these risks, ketamine should be considered a really important emergency medication, especially for people with treatment-resistant depression, because it has life-saving properties. So I'm going to read an excerpt from a New York Times article that came out last May about an author who has treatment-resistant depression and she tried ketamine treatment. I think she does a really good job of describing how difficult it is to have treatment-resistant depression. So just in case that's something that you're sensitive to, you can mute for the next few slides. So she says, the summer I was 26 years old, I moved into my parents' home in the Chicago suburbs because I could no longer care for myself. I'd been severely depressed for most of my life, but that summer 5 years ago, even the most mundane tasks became insurmountable. I spent days on the couch where I rarely spoke, my mind so dull I struggled to form words. I lay at night thinking, I can't go on like this. Some people experience episodic depression, but since the onset of my illness in early childhood, I sank far and fast and never truly surfaced. By age 10, I found myself overcome with inexplicable dread, so ill at ease I could hardly sit through a television show. By the time I was a teenager, I awoke every morning to an immutable sadness and sobbed on my bedroom floor. Though I was an excellent student, I struggled to make it through class. Finally, at age 16, I dropped out of high school. Over the years, I tried every available treatment. I stayed in psychiatric hospitals, underwent years of therapy, and tried a pharmacy's worth of antidepressants, but my condition never improved. And so she tried a serial ketamine infusion. After the first infusion, she wasn't feeling any improvements in her depressive symptoms, but after a few infusions, she said, it was as though a switch had been flipped on and my brain lit up. I noticed color creeping back into the world, and the hard knot of dread and dispassion in my chest melted away. My productivity skyrocketed. Within a couple of weeks, I had cleaned and organized my apartment, applied to and been hired at 2 jobs, started a meditation practice, and begun learning a new language. Though my jobs were poorly paid, ketamine allowed me to utilize the skills I'd learned in therapy to reframe my experiences in a positive light. Bleaching gym mats in a martial arts studio and washing buckets in a flower shop became meditative practices rather than drudgery. I hardly recognized the buoyant person I'd become. When my brother got his first pair of glasses, he marveled that he could see individual leaves on a tree. Ketamine felt a lot like that. To be in awe of simple pleasures felt like a reason enough to live, and I was overcome with a quiet revelation. This is what it means to be content. So I think, again, this is a really interesting article, and anyone has the New York Times, I strongly recommend it. But I think it really emphasizes, how difficult it is to live with treatment-resistant depression and what kind of life-saving properties ketamine can have for these people. So again, ketamine, kind of like a lot of other psychiatric drugs, it was discovered by accident. And for some reason, it works really well, but we have no idea why. So now it's our job to kind of backtrack to try and understand what's going on. So this is where my research comes in. There's a lot of questions that we need to sift through. First and foremost, what in the heck is causing this antidepressant effect? If it works so well in people who don't benefit from any other treatment, maybe it's telling us something about some kind of key system in the brain that's causing depression that we haven't uncovered yet. And maybe if we figure that out, we might learn a lot more about depression and figure out better ways to develop better antidepressant medication. Also, we think about if it's, I want to know if we can isolate the antidepressant mechanism of ketamine without the dissociative side effects. What if you don't want to take a 2-hour Uber trip with a clown? If we can isolate that antidepressant mechanism, we can develop drugs with even less side effects that could be used at home. So ketamine works great, but like I mentioned, it's really expensive and it requires medical supervision. That means you need money and you probably need to live in a metropolitan city to have access to this treatment. So we know the suicide rates are particularly high for people in low socioeconomic statuses and in remote areas. So we need to figure out how can we get them treatment. Also, it's only 60 to 70% of people with treatment-resistant depression who respond to ketamine. We need to shoot for 100. What is it about those 30 to 40% of people that makes them not respond? Since there's no empirical diagnostic tests for depression, maybe we can identify patterns or what we call biomarkers that help us predict whether or not a person will respond to a treatment. That way we can potentially improve personalized medicine and spare people the 2-hour Uber trip with the clown if it's not going to work for them. Also, how can we take advantage of this remission window, right? If a person is finally feeling good, we need to get them all the help they'll be receptive to in that time. So figuring out how do we take advantage of that time that they're feeling good so we can help them through their next depressed episode. Also, we need to learn about the long-term consequences of ketamine, what that ketamine tolerance looks like at the sub-anesthetic dose to make sure that whatever treatment we recommend is safe. So I'll give you an example. Ooh, hopefully. Okay, I'll give you an example of the work that we're doing at UCLA to study ketamine. So we actually just wrapped up data collection for a project that's funded by the National Institute of Mental Health, looking at serial ketamine infusion. So we collected data here at the Amos and Lovelace Brain Mapping Center, and we were inviting people with treatment-resistant depression to come into the lab. Before we gave them the treatment, we would do a brain scan, some behavioral assessments, and a blood draw. And we would repeat those measures 24 hours after their first infusion and 24 hours after their serial infusion, and then 4 weeks after they finish the treatment. So that way we can see at every stage of the treatment, what is going on, what are the changes that are happening, how is this patient feeling, what is their brain looking like, and then what does it look like afterwards. And what we're seeing is really exciting. It's in line with what other people have found. So this is data from our study, and we saw profound reductions in suicidal thoughts 24 hours after the first infusion, 24 hours after the fourth infusion, and these reduction in symptoms was sustained for the 5 weeks following. We also see reductions in apathy and anhedonia. But we want to know why. So what is driving the antidepressant response? There are a few theories. One of the one that people kind of jump to is molecularly, ketamine is an antagonist for a specific receptor in the brain. So we're back in our synapse, and as one cell is transferring neurotransmitters to the next cell, there's receptors that catch them, right? So ketamine is thought to have a very specific effect on a specific receptor in the brain, and essentially it clogs it up, and because of this, this triggers a chemical cascade that causes the formation of new synapses in a process called synaptogenesis. Synaptogenesis, give me a word, any word. Anyways. There's a lot of that in this, but these synapses are basically new connections between brain cells, and the formation of these new synapses lead to changes in brain circuitry. And we think that possibly is what's contributing to this antidepressant response. Sounds great, but the problem is there's other drugs that have that same effect on that same receptor, and we're not seeing the same antidepressant effects that we see in ketamine. So we need to dig deeper. And with the help of animal models, we can actually peer inside the brains of rodents, for example, to see these new synapses forming after ketamine. So this is actually a microscopic image of a neuron, and you see these tiny little dots are the synapses. So we can artificially induce some form of depressive state in the mouse, and we see less synapses. And when we give them ketamine, there's new synapses that grow. Now, people often try to use animal models to work out the underlying neurobiology. And again, they can do this because you can actually cut the brain open. But a rodent is very different than a human. And our goal is not to cure depression in mice, but it's to help people with depression. So we can learn a lot about neurobiology of depression in animals, but we really need to be investigating humans. So finally, I'll talk about MRI. This is the work that I've been doing. So MRI, or magnetic resonance imaging. I'm sure a lot of you are familiar with MRI, have possibly even had an MRI. But basically, it's a giant magnet like you see right here that when you stick inside, we can actually get live images of your internal organs, including the brain. It's super safe. There's no radiation involved. Actually, the real only risk is it's a giant magnet, so you can't be wearing any jewelry or have any metal in and or around you. So if you have medical implants, we have to make sure that they're MRI safe. Typically nowadays, most medical implants are made of titanium, so they're not magnetic, so it's okay. But otherwise, like I've had bobby pins kind of float around my head when you walk into the scanner room. It's very strong. But essentially, because it's a magnet, we can exploit the magnetic properties of the tissue in your brain to get different types of images. For example, we can get a picture just of your brain, what it looks structurally. We can model the connections in your brain, and we can look at brain activity. So doctors typically look at these brain MRI scans to look for abnormalities. Just with the naked eye, you can tell this person is pretty healthy, and this person with Alzheimer's has quite a bit of shrinkage going on. And this person with stroke has a giant stroke lesion. It's very clear with your eye that there is a problem here. The tricky thing is this is macro scale, right? People with depression have very similar looking brains to people who are healthy. There aren't any major structural damages that happen that you can see just looking with your eyeball. So again, you can't diagnose someone with depression just by looking at their brain scan. But what we can do is turn this black and white image into data. And that way we can quantify what's happening to the brain when someone is depressed or after you've given someone ketamine, for example. So I've been really lucky to work with some of the pioneers in the field who have developed these tools that allow us to label and measure brain sizes. And so what we're finding is, although they're not big, there actually are structural differences in the brain with people with depression. They're just very subtle. And we need advanced technologies to detect these changes. We're seeing smaller regions involved in emotional behavior and emotional regulation in people with depression. So like I mentioned, it's not like Alzheimer's disease or a stroke where you can really see the big change. It's a lot more subtle. And so we think this could partly contribute to the stigma about mental illness because it's so hard to detect. So if you have a broken bone, you get an x-ray and the doctor says, hey, that's a broken bone. We should treat that. Now, with this advanced technology, we've identified our broken bone. It's just a lot more subtle. There is an injury here, just at a very different scale. So now I don't want you going out and thinking, oh, my friend or my family member who has depression, their brain is shrinking. That's not what's happening. But what we are seeing is these very small differences in people with depression that we think is actually driving a lot of the symptoms. So why is it important that we're seeing this injury to the emotional and emotional regulation centers? Well, a lot of brain MRI have helped us come to this conclusion that some of the symptoms of depression might be driven by broken brain networks involved in emotional regulation. So what's emotional regulation? Normally, when you encounter an emotional stimulus, you might have an inherent emotional reaction. Say you're watching TV and like something really sad happens on the TV. You'll get really upset at first, right? But then you have this cognitive evaluation. Okay, it's on TV, it's a fiction show, it's not that bad. And you kind of regulate your emotional response to it. Now, in depression, what we see is heightened emotional response and a lot of difficulty cognitively evaluating that emotional stimulus. So people with depression have difficulty regulating how they respond emotionally. And so we're seeing these smaller regions involved in cognitive evaluation. So I don't know if my pointer is too small, but in these frontal areas here, it's called the prefrontal cortex. That's typically involved with this cognitive evaluation. And then the emotional centers of the brain that kind of live in this area, including the hippocampus and the amygdala. Interestingly, after ketamine, we see that these emotional centers actually increase in size. So this makes us think that it's possible that ketamine may be targeting this system. Now, this is just size. Size can mean anything. Luckily, we can investigate this further by looking at brain activation. So to look at brain activity, we still use MRI, but it's one of the versions of MRI called functional MRI, where we measure blood oxygen level dependent or BOLD signaling. So what does this mean? When a neuron fires, it needs oxygen so that it can keep firing. And the blood supply that's passing by these neurons that are firing is like, hey, I got you, here's some oxygen. And so that transition between oxygenated to deoxygenated blood supply can actually be detected by the magnet. So what we do is using functional MRI, we capture this change in oxidation of the blood flow, and we create these activation maps where we assume that based on the change in oxygen level of the brain supply in those regions, there's brain activity going around there. And so we can look at how this brain activation changes when people are doing different tasks or when they're at rest. And essentially we can try and parse out networks of brain regions that work together to perform particular tasks. We call this functional connectivity. So what we see in depression is a lot of hyperactivity in regions involved in emotional responses and underactivity in regions involved in emotional regulation. So here's an example of a study that looked at functional connectivity with the emotional regions of the brain. It's a complicated figure. I'm just going to have you focus on this part. Like we said, we typically see hyperactive emotional regions involved in emotions. And what we see after ketamine is a profound reduction in that hyperconnectivity that is actually associated with improved behavioral symptoms. So this is suggesting that ketamine is targeting this hyperactive emotional response and turning it down, kind of normalizing it. So we also know that there's evidence that ketamine is targeting this emotional regulation, so the connections between the cognitive evaluation and the emotional centers. So this is a study actually from my group from a postdoc who left a few years ago. And what they found is they were looking at connections between an emotional region and regions involved in cognitive evaluation. And if you look here in healthy controls, this gray area, so people without depression, they have strong connections here. But for people with depression, there aren't, that connection isn't as strong. And after ketamine treatment, after the first infusion and after the fourth infusion, we see an increase in these connections. So again, it's this idea of ketamine might be helping normalize, helping these regions speak together again. So in summary, the thing that we've learned from a lot of the brain imaging research in ketamine is that ketamine's therapeutic response may at least in part be driven by its effect on the emotional regulation network. So we see it reduces hyperactive emotional responses and increases connections between the cognitive and emotional regions, kind of trying to help regain that balance. But there's so much left to learn. Again, we're working backwards. We still don't know why ketamine works so well in treating depression. We've identified one circuit, but there's so many other symptoms that are involved in depression. So there's a lot left to learn. Additionally, the thing that's particularly difficult is psychiatric neuroimaging is stuck in research. We aren't using it in the clinic, and we don't have the means to use it in the clinic yet. We still have too much to learn. So I think it's really important that we focus our research on being patient focused. So we need to figure out how we can tailor our research questions to align with patient concerns more. Please, okay. I think the most exciting thing about this field is that it's very young. I've actually been working on a review paper covering publications that look at brain changes after ketamine in people with depression. And there are less than 50 papers out there. actually the first neuroimaging paper came out in 2011. So there are so many questions we haven't even begun to start asking yet. And so I figured I would wrap up by, since I know it's a scholarship committee trying to help people who are interested in academia and in academia, pursuing higher academia, how can you get involved? It's a very interdisciplinary field. You can even tell just by this talk. I started talking about clinical depression, and then I started talking about pharmaceuticals, and then we got into brain mapping, and then we like merged them all together. So you can really attack these questions from so many different angles. Just for the sake of time, because I know I've talked for quite a while now. Right, typically it's a professor who runs the study. They have a PhD or an MD. They involve psychiatrists, neurologists, pharmaceutical companies. I'm the postdoctoral research scholar who works with graduate students. We work with data collection, but also analysis. You can go at this from so many different angles. My training was mostly computational. I worked a lot with computer scientists, biomedical engineers, electrical engineers to test out and develop the software that we're gonna analyze these brain networks with. But you could decide to pursue psychology and be more interested in how do these symptoms change? Or you could say, I want to know about the neurobiology, and you could go into genetics. So you can attack it at a bunch of different angles, but you don't need to go to grad school for this. You can be a research assistant in a lab. You can work at a philanthropy that focuses on getting money to research that's happening. There are a lot of startups right now that are focusing on mental health. So there's a lot of different options to get involved in this kind of research. I'll wrap up now. If you have individual questions about those, I'm always happy to talk. This is my email. Just to acknowledge, my advisor is incredible. Her name is Catherine Nahr. She has a really great team at UCLA at the Brain Mapping Center. The project that we have is really cool. It's funded by the National Institute of Mental Health, but I also got funding from the Neurological Disorders and Stroke of the NIH to do some of this research. And of course, thank you to the Hellenic University Club of Philadelphia for giving me the great graduate scholarship award that really helped me in my last year of grad school. The end. Questions?
Oh, wow. Wow, thank you so much. I don't want to unmute people altogether to clap because it will be chaotic, but at least silently, we are clapping. Thank you so much. This has been amazing. I mean, wow, I didn't expect that I would learn so much today. And yeah, it was also nice. Definitely I have questions, but I will be a gracious host and give the floor to people attending. Please unmute. I see hands. Yeah, let's do it by hands. Okay. I mean, you can raise your hand and I'll call. So I think I saw Anna first. So Anna, you're unmuted. Do you wanna go ahead?
Sure. Artemis, this is absolutely amazing. And you can tell how passionate you are. Really great listening to you. My question is, why is so much research being done with this medication? And yet it's not available for large portions of the population. And we have so many people suffering from depression. So what can be done about that?
Yeah, that's a really interesting question. So I've been talking about this a lot over the last few days. One of the things that's interesting is there's some stigma around the concept of ketamine as a drug. I see it even in some of the texts, like the scientific literature that I'm reading, explaining like what are the negative effects of giving ketamine as an antidepressant. And people are a little skeptical, right? Because as a psychotropic medication, it kind of has this negative connotation around it. So again, the research is really taking off all from, I had said a lot of the research has been done in the last, since 2011. Most of those neuroimaging papers only came out in the last few years. So I think one of the things about science is science takes time and research takes time. And so in order for these studies to be published and for people to kind of create a really good foundation of why this is good, why this is safe, and how we should use this, it takes time. And I think we're starting to get into that world now. Mm-hmm. Trick is, how do we dive deeper into that world, but prevent you know, people trying to profit off this kind of medication because it's not FDA approved yet.
Right, right.
That's the tricky area.
Thank you.
Tom.
Yes, I wonder, would you have some comments about the bipolar condition in depression? I had a good friend who ran on high for 20, 25 years before he was really diagnosed as being bipolar, and it proceeded to destroy his life. Whereas during those first 25 years, he was on a high of productivity you would ordinarily not see in a human being.
Yeah, definitely. Bipolar is really tough. And one of the things with depression and a lot of these psychiatric conditions is they're often comorbid. So we see them happen at the same time. So depression is really often comorbid with anxiety. Bipolar is often misdiagnosed first as depression because a person might first present with depressive symptoms. And a lot of the times people who have schizophrenia go through this crazy process of first they're diagnosed with anxiety, then they're diagnosed with depression, then they're diagnosed with bipolar, and they don't actually get an accurate diagnosis until much later on. So I'm not going to make him talk, but my boyfriend's here and he basically has this really cool project. I'm going to gush about him for a little bit. But there's this new thinking in the psychiatric field where we kind of need to reframe how we consider this diagnosis because we're misdiagnosing people so often. So he's leading a project where they're kind of saying, okay, maybe what if we drop the diagnoses and we just look, what are brain structural similarities that we're seeing? What are genetic overlapping markers that we're seeing so that we can kind of try and better quantify what each disorder is? Because they might all be the same thing, right? Diagnosing someone as having depression and having bipolar and schizophrenia essentially is because we were trying to look for a way to help these people. And the best we could do at the time is create these boxes to put them in. But now as research is advancing, we're kind of learning maybe those boxes really aren't that secluded. And maybe we need to reconsider how we're quantifying these diagnoses and how we're treating these people.
Yeah, he had a very difficult time for 25 years. He died about 3-4 years ago in 86. So he had a good long life, but the productive part of his life really lasted until he was in his mid-50s to 60. And it was really difficult. They tried one drug after the other. You mentioned Zoloft, and he was on Zoloft and on a whole variety of different drugs. And he was never fully controlled.
Yeah, and I think that's actually one of the scarier things about bipolar disorder is that when it's misdiagnosed as depression, sometimes when you give someone with bipolar an antidepressant, you can trigger a psychotic episode. So you actually throw them into their manic psychotic episode, which is really difficult. But yeah, there's a lot of research going into trying to figure out how we can help people with various mental health conditions. And I think one of the things that's promising is people are at least talking about it more and actually considering it more seriously, like actually as a medical condition and not just like that person's crazy, like I don't know how to deal with them. It's, you know, you break your bone, you put a cast on. We need to figure out what the cast is.
Thank you. We only have one more minute. Any other? Yes, Nikki.
Hi, Artemis. I really learned a lot listening to your talk today. Thank you. I read about ketamine today in preparing for your lecture because I really didn't know much about it or anything. And I read when you were talking about the receptors that it works on in order to produce its effect. Do you know what percent for the glutamate receptors that it works on, and what percent are the opioid receptors?
Yeah, so we see both. So that's again one of the reasons why that's just one theory of, so it's this NMDA receptor that we know ketamine itself as a molecule is an NMDA receptor antagonist. And so that's one theory of the mechanism that happens. But there's research that shows that ketamine actually has effects on the opioid receptors too. So again, trying to figure out what kind of combination of things is happening is really difficult. So one of the things that I'm pretty excited to do at UCLA is I just won some funding to look at changes in gene expression after ketamine. So as we are collecting brain imaging, we're also collecting blood samples, and we can look at how different genes change in the way that they express themselves throughout the treatment to try and give us hints a little bit more as to what's happening molecularly. So maybe it is this synaptogenesis and it's something that's very neurotrophic, versus it could be something completely different. But I'm really excited to look into this because this is, again, kind of relatively new, and having a field where people are integrating so many different disciplines, I think is like the right way to move forward.
I wanted to also ask you for the nasal spray, are patients allowed to use that at home?
No. So it's still just, I mean, it's good for people who are afraid of needles, but it's still, right, it's going to induce some pretty intense side effects. And so it's not at the point where legally people are allowed to take it by themselves.
I will make one exception today because I see people wanna another 3 minutes, but 5 after 8, I promise I will stop it. But I see Anna has a follow-up question. Anna, I see your hand up.
Thank you so much. I have so many questions, but Artemis, what made you go into this field? What excited you about this?
Yeah, so I had done a summer program at Oxford when I was in high school. That's really great. I think it's called Oxtrad. I can't remember at this point. I thought initially in high school I wanted to be a doctor, but when I took these classes, I started to learn about psychology, and one of the teachers suggested neuroscience. And at the time, my grandfather had Alzheimer's, so it was like a really unfortunate, but also really interesting scholarly experience of experiencing to see what it's like to have someone physically look okay, but their brain to be really sick. So that's kind of how I started. And it's interesting, when I was in grad school applying for some awards, someone was like, I don't want to read another neuroscientist who had a grandparent with Alzheimer's and that's why they wanted to do. I was like, oh man, but it's true. But yeah, I think it's one of those, it was a really good undergraduate option for a major because it lets you can use it as pre-med, you can use it to go to grad school, you can use it to go to PT school, occupational therapy school, like all these different career paths start from this. And I think for me, honestly, I think shallowly, I think brain images are beautiful, and what we see from it is really exciting. And that was my initial reaction as a sophomore, and that's just something that I just kept chasing.
Bravo, so thank you so much.
Mm-hmm.
So now we have 1 more minute after the extension. Anybody else has a question?
Very nice.
Kostas has a question.
Can I ask you, Artemis?
George.
Yeah, George.
Yes.
First, George. Yeah.
Yeah. Just very briefly, based on your experience, is there enough research that addresses most of the issues, or we need more research to address other key issues in depression?
That's a really good question. I think it's not about the amount of research that's happening, but I think it's about the communication between the fields doing the research. So, there is a little bit of animosity between the people who study neuroscience in animals and the people who study it in brain imaging, and they don't always communicate a lot. And they don't always loop in the psychiatrists and the pharmaceutical companies. And so I think it's not about doing more research, but doing more efficient research and communicating more.
Thank you.
Mm-hmm.
And Costa, the last one?
Yes. This was a wonderful talk, Artemis. Really, thank you so much. I'm wondering, from the imaging side, when will be the case when you are going to go to the psychiatrist and instead of answering 150 questions, you're going to just do an MRI and they will tell you
this is
like,
what's happening.
A diagnosis. Right?
I mean, We could talk for hours about this. I think it's going to be a while. I mean, I feel like maybe I should have been a little more negative about how much is left to learn, because we're really just scraping the surface with this brain imaging, right? We're assuming this oxygenated to deoxygenated blood switch means that there's brain activity there. I mean, it seems like maybe, but that's still not very direct. So I think it's going to be, well, I'm going to say, I hope it's going to be a long time before we include this kind of brain imaging instead of diagnostic markers, just because of how much we have left to learn. I don't want an Elizabeth Holmes situation happening.
Okay, so I'm going to stop now. Thank you so much, Artemi. It's been an honor, really. We will, as I said, have the recording and we will share it. We also want to make sure that we become a little bit more active in getting you guys connected. And you guys, I mean, not only us, the kind of older generation, but the younger generation. There are a lot of people right now actually in the audience. And we will be sure to reach out back to you, because I think there are some, you know, I mean, even the experience what you talked about today, I think there are wonderful opportunities to, you know, continue talking with each other and exchanging ideas about your research. And maybe you will also help into that interdisciplinary part that you thought would be important. So again, thank you so much. Thanks everybody for joining us today. And I will keep you posted with our next speaker, hopefully another HUC scholarship recipient in the fall. Thank you, Artemis, we really appreciate it. And
bravo, Artemis, bravo.
Bye, everybody.
Bye-bye.
Bye-bye.
Turn it off.
Okay, so you're muted.